Hi everyone, I am so sorry that this video is so late. Unfortunately, I had an emergency with my family that I had to deal with. Everyone's okay, but it kind of pushed me back a little bit with what needed to be done today. So your test is created. It is worth 80, actually it's 80 points or 80 questions. So they're worth about 1.25 each. There is a lot of labeling. This is going to be a short and sweet video because I just wanted to get Lab A and Lab B all on the same page as far as the quiz is concerned. So hopefully this is helpful, and I hope everybody's been studying. Just to reiterate, I did put a couple announcements up on Blackboard, but this is only going to be on cranium this week coming. The following week we'll do the rest of Chapter 11, which would be facial bones, sinuses, TMJs, orbits, that kind of stuff. But this week is only cranium, and any part of the ear will not be on the test. I know that Lab A did not cover the ear, or they might have just a little bit for basically the equilibrium, but that was it. So out of fairness, I wanted to make sure that everybody was on the same page and covered the same material, so we will not have ear on this coming test. Okay, so let me start the slideshow and get going with everything. And I will get my little pointer ready. Okay, so Chapter 11, Cranium. Now, you are going to be responsible for labeling. I'm going to try to make sure that when your tests are printed out, the labeling section is in color so that you can easily identify what the lines are pointing at. But, you know, I am putting on here things that you need to know. Definitely this lateral one here is of importance, so make sure that you know each portion of it. And this is already labeled for you, so real quick, this is the ethmoid, this little blue area here, your frontal, your parietal, back here is your occipital, and if anybody remembers, this little protuberance back here is your inion. And here is your temporal bone with your mastoids here, your styloid process coming off, and then this is your zygomatic process of your temporal bone. And then only on the lateral you can really see the greater wing of the sphenoid bone. And that's really it. This is your lacrimal here, but it's not really part of the cranium. That's more of a facial bone. So that is what the lateral is going to show you. So make sure you pay attention, especially to the lateral, okay? Parts of the cranium that are important to know, you need to know the different sections of the cranium. So you've got the calvarium, which is the skull cap, and then you've got the floor. So the calvarium includes your frontal, both parietals, and your occipital. And then the floor includes both temporals, your sphenoid, and your ethmoid bones. Moving on, this would be the view as if you were looking up into somebody's eyes. This is the front region of your frontal bone. Here is your ethmoid notch, which you wouldn't really ever see maybe on CT, but definitely not an X-ray, but your ethmoid notch is here. You've got your superciliary arch, your nasal spine right here, your orbital plates, your frontal tuberosity or eminence, and you know your glabella is a super important external landmark for any type of positioning that you're doing. So this would be the anterior portion, and then back here would be the posterior portion of your frontal, and that is what it looks like. Moving on to the lateral view again, just to highlight the temporal region one more time. I did talk about it earlier, but this is the temporal bone. This is the mastoid portion, and inside there would be your mastoid air cells. This is the squamosal portion. That's the most likely to fracture in this area here. This is the zygomatic arch, and this would be the zygomatic process of the temporal bone. Remember me telling you that anytime a bone projects into a different bone, which would be your zygoma here. It's the process. It's always named for the bone it's projecting towards. So this is the temporal bone, and it's the zygomatic process of the temporal bone. So it's going towards the zygoma. And then you've got your styloid process here, which kind of looks like a needle, or like a thorn, I guess you could say. And here's your EAM back here. It's kind of hard to see on a radiograph, the EAM, so you'll see in a subsequent slide that I did actually, or you'll see that I'll point it out again to you so that you can see it a little bit better. That's a tough one to find. And then, of course, your occipital, your parietal, your frontal, your greater wing of your sphenoid here. And in here would be your ethmoid. And then you've got some facial bones, which aren't going to be on this test, so I'm not going to cover them right now. Now, this is an interesting view that you may want to familiarize yourself with. This is looking down into the sphenoid. So here is your sphenoid here. It looks like a bat. And the reason why this view is super important is because on this view, you can actually see the foramina, or however you want to pronounce it, the holes that allow the vasculature and the nerves to go through. So this hole here is the foramen rotundum. This one is the foramen ovale. And this one I think is kind of easy even on a radiograph to identify because it's the most oval looking of the foramen. That's why it's named as such. And then here is the foramen spinosum back here. And then you've got your clivus. This is your dorsum sellae, the sella turcica, and this is where your pituitary gland would sit. And then you've got your anterior clinoids. You have two of them. You can see the lesser wing is up top, your greater wing is down here. And that's just looking down again into the sphenoid. You can't really see it from this vantage point when you've got your parietal bones sitting over them. This is a lateral view of the sphenoid. If you remember me talking, or if you're in my lab group, I always say that the ethmoid and the sphenoid are important. All our bones are important, but the ethmoid and the sphenoid have a lot of bony landmarks that you do need to know, so I wanted to stress them to you. This would be a lateral view of obviously your sphenoid, and this is the sella turcica. And the reason why I like to emphasize the lateral view of the sphenoid is because if your sella turcica is completely in profile, so if you didn't actually see this section and all you saw was the outer edge, that means that you have a good lateral skull or lateral facial bones image. So the sella turcica is really your tell if the patient is rotated or not. So that's really important. But for the picture here, I think just for imaging purposes, it's showing you this extra section. Even the clinoids are not superimposed, and I think that's just so that it can illustrate what the section is. Here's again, your anterior clinoids. You've got posterior clinoids. And then this is kind of a better view because then you could see your clivus down here and then your dorsum sellae, dorsum meaning the back or dorsal region, if that can help you kind of remember where it's located. Moving on here, the ethmoid bone. Again, I stress the sphenoid and ethmoid very much, and particularly this image is important because it kind of breaks it all down for you. So this is as if you were looking into the skull. Here is your sphenoid here, and you've got your foramen rotundum again, your foramen ovale, and your foramen spinosum. This is your foramen magnum, not your obturator foramen. That is a common one that some people can get confused. So the foramen magnum is here, and this is where your spinal cord is going to go through. And then over here, this is part of the ethmoid as if you were looking down into it. This ridge here is called the crista galli, and that's what kind of sticks up when you're looking at an image, and it sticks up through your frontal sinuses. Just inferior to the crista galli is the cribriform plate, and you can see it kind of in both sections there. You've got the lateral labyrinth or mass, and it's called the labyrinth because if you can see in here, it's kind of like lots of nooks and crannies to go through. This here is an easy one to remember because it's completely perpendicular and it's in the shape of a plate, so it's called the perpendicular plate. You've got your superior nasal concha, which is where all our lovely mucus likes to collect when we're sick. And down here is your middle nasal concha. Excuse me, guys, I'm like losing my voice. It was a rough day. Oh, okay. So moving on. Those are the basic landmarks that you should know for your ethmoid bone. Very important. Okay. Cranial sutures and junction points. So the cranial sutures are basically where our fontanelles actually merge, and these sutures are immovable. So they're not going anywhere. Let's hope they don't go anywhere, because that would be bad and we don't want brains sliding around everywhere. But the sutures are important. You need to know them. You've got your coronal, which lines with the coronal plane. Here's another view of it. Your lambdoidal, which is back here. So here's your two parietals, and then your occipital, and your lambdoidal separates your parietals from your occipital. The reason why it's called your lambdoidal suture is because if you know your Greek alphabet, lambda looks like this. So it's like a triangle without the bottom. So that's lambda. Your squamosal sutures go across the squamosal portion of your temporal bone. So if you can remember that, that makes it easy to remember that suture. And then of course your sagittal suture would be in line with your sagittal plane. So there it is there, and here it is in another view as well. The junction points are where the sutures meet, and these were usually the locations of fontanelles when you were a baby. So the junction points, you have your asterion, which is back here. So your lambdoidal and your squamosal sutures make up your asterion. Your bregma, which is on top, and here's a good view of the bregma. So your bregma is the junction point of the coronal and sagittal sutures. You've got your lambda, which falls in line with your lambdoidal suture and your sagittal suture. And then your pterion, which is up in here, and that's your coronal and squamosal sutures that's happening here. So those are your junction points. And I did mention fontanelles a couple times. Here's a little bit about them. They're membrane covered. You are born with 6 fontanelles. You've got your anterior and your posterior, your right and left sphenoid, and your right and left mastoid. And you can see them here. Here's mastoids. Sphenoid, which goes in line with your sphenoid bone. Your mastoid falls in line with where your mastoids are eventually going to develop. Your anterior, which is close towards the front of your head. And then you've got your posterior, which is back here where your lambda would actually be. And one of the important points is, you know, everybody wants to know, when do our sutures, or when do our fontanelles close to create our sutures? And your anterior one is usually the last one to close, and that one closes around 18 months of age. So these are the soft spots that you would feel on a baby's head. So you got to be careful with those. So now that you know where they are, you can make others aware to be careful of those areas. A little bit more on fontanelles. Just a breakdown as an infant, where they are and then what they turn into, which is kind of what I said at the previous slide, but just so that you're aware. So the anterior fontanelle goes into the bregma. The posterior fontanelle changes into the lambda. Your right sphenoid turns into the right pterion, and your left sphenoid turns into the left pterion. Make sure when you're taking anything lab related, so any type of anatomy, all my tests, if it is easy to tell if it's indicated by a marker on a radiograph, or if the side is delineated for you, you must put the side that you are labeling. So if I want the right pterion, please put right pterion. If I want left pterion, please put left pterion, and that goes for anything. So spelling is super important. Make sure that you know the spelling. Some of these words are very difficult, and also make sure that you know right from left. If it's marked by a marker, you are responsible for giving me the side. Okay? Just a little disclaimer there. And then back to this, your right mastoid turns into your right asterion, and your left mastoid turns into your left asterion. Again, these are tough to remember to spell, so please, please practice that. Okay, something you might get is this type of image here. Now, the images are going to copy not all that well. I haven't figured out the best way for them to copy over. So if you have questions during your test, you're welcome to come up and just be like, hey, is this pointing to the suture? Is this pointing to the petrous ridges? Or come up to me and say, hey, I think this is pointing towards the suture. Is that right? So that I can tell you. I'm not going to flat out give you the answer, but if you're telling me you think it's this, then I'll say, yeah, you're on the right track. But real quick, this is a radiograph of the apiaxial projection or town method. Town means downtown towards the toes, so you're angling 30 degrees down or caudally. And I'll just go over some of the points here just so that you're aware of it. So letter A down here is pointing to your dorsum sellae. It is kind of hard to tell. It's even harder to tell on a plain picture or on a plain piece of paper. So just be careful here, but this is the dorsum sellae over here. B is pointing to this section here. So this is actually your sphenoid, if you can see it. I know it's really hard to see. I'm blind, so it's even harder for me to see. But this is your sphenoid. And then here are your posterior clinoid processes. And then if you go over to letter C, these are your petrous ridges. The petrous ridges are kind of easy because they always look like a big glob of white something. You're not really sure what it is, but you know there's a lot of bone there. That's always going to be your petrous ridges. And then D is going to be your parietal bone, which I know is weird, but that's what it's pointing to, is your parietals, because it's the side. F is going to be this section here, which is your foramen magnum. So what's important with your apiaxial town is to remember that you should be able to see the dorsum sellae of the sphenoid in the foramen magnum without superimposition. If it's superimposed at all, then you know that there's some kind of problem with your positioning or with your degree of angulation of your central ray. So when you're taking the test, you have to look at the, I don't even remember what your book calls it. Oh, evaluation criteria. I'm really big on evaluation criteria. You do have several questions that are situational, that's asking you to correct positioning, or is the positioning correct the way it's been described. So please make sure you pay attention to the image evaluation or evaluation criteria. That's important. Mainly, I want you to know positioning and if it's correct. So please pay attention to that again. Anyway, I forgot where I left off. I think I was on parietal. I'm sorry, I'm kind of rambling, but I'm extremely tired. I don't even know what time it is. My dog is snoring and it's 1:07 in the morning, so just trying to get this out for you. E is pointing, this section here is actually your occipital bone. So I don't know if you could see, but can you see the suture line here? That's a suture line, that's a suture line, and then there's a line going this way. This is your occipital bone, and this is your lambdoidal suture here. So that's what you're looking at. I know it's kind of funky looking. This is the alien shot, I like to call it, but that's what it looks like. Oh, hold on, I need another drink of water. Make sure you get the town down. Or downtown, whatever. Anyway, again, I'm rambling, I'm tired. Let me look at the lateral projection. Now, lateral projection is very important for both facial bones and cranial bones. You need to pay attention to this region here, which is the sella turcica. It is in profile so that you know the patient is not rotated. For lateral skull, you want to make sure you have the entire skull on. When you go into facial bones, you don't need the entire skull, you just need this section here to ensure that you get all the facial bones. So right here, if you were doing for facial bones, the mandible would be cut, but for skull, this is perfect. We can see everything that we need to see. if you were to get a radiograph like this, you would have to label all the areas of interest. The ones that are a little bit more difficult to see, I would probably provide for you just because it wouldn't be fair. So like, remember I said the EAM is really hard to see. This letter A here, that's actually pointing to the EAM, and you can't really see the hole. So, you know, something like that I would give to you, but the rest of it you would be responsible for. This section here is very difficult to see, letter J. That's a suture line. So even on the computer screen, it's difficult to see, and on your printed tests, it would be even more difficult to see. So if you have a question like this, please feel free to come to myself or Dr. Hicks or whoever is proctoring, and just to make sure that you are certain of what it's pointing to. But in this particular image is pointing to the suture line here. So then back here, if you're looking at D, this is also pointing to a suture line. And that suture line would be your lambdoidal suture because it's on your occipital region. Okay, PA Caldwell. PA Caldwell, you can see the little L here, so that means you should be able to tell me your left from your right. So if I asked you what letter A was in your PA Caldwell, you would tell me it is the right supraorbital margin that it's pointing to. And here is your Christogali, which I said does point up into your frontal sinuses, which are right here, and that's what letter D is pointing to, is your frontal sinuses. C is actually pointing to another suture line. I know it's really hard to see, but it's the suture line, that's your sagittal suture. And then what do you think these big glob stuff here, this section, this would be your what? Well, not that you're going to answer me, but this section here would be this is your zygomatic arch, but these are your petrous ridges here. So let me make sure that I'm giving you the proper information before I move on. I'm dropping stuff. I've got like 3 computers going and all kinds of stuff happening so that I can get this out to you. But like I said, I'm tired, so I want to make sure I'm telling you proper information before I lose my mind. Okay. All right. Yes, moving on. SMV. SMV you would most likely do for facial bones. If you were to get this image for cranium, you would not really be responsible for naming the facial bones portion of it, but the cranial portion of it I absolutely would want you to label for me. Particularly the foramen that you can see here, and that's why I'm using that in particular as an image. So if you look at, and I know this is like just as hard to see as the sutures, but right here and right here, E and F, those are pointing to 2 foramen that you need to know. So E, and remember you saw in an earlier slide, this is very oval shaped. That's your foramen ovale. And then right back here is your foramen spinosum. So those are 2 that are important. That's why you would get an SMV radiograph specifically so that you could point out the foramen for me. And then, of course, there's other things that I would want you to point out. Obviously, this is the foramen magnum here. H would be pointing to your petrous pyramids, which again is a big glob of white here. These are your sphenoid sinuses. Just so that you know the basics for cranial stuff on a slide like this. Now, I have given you this in Lab B. I'm not sure if Lab A has seen the Quiz Me stuff in the PowerPoints. These are all available to you in the initial PowerPoints posted, but just to go through them, the widest portion of the entire skull is located between and the answer would be parietal tubercles. Oh, there we go. The jugular foramen, where would that be located? Now, there's been lots of contention as to where the jugular foramen is. That's not really going to be on your test, but if you were curious as to where the jugular foramen is located, then I would tell you it would be on your temporal bone. Can't really see it though in anything that I've shown you, so we'll just move on. Skull morphology and topography. Morphology means the shape of the skull, and you do need to know the shapes that's important for positioning. There's 3 different shapes. There is the mesocephalic, the brachycephalic, and the dolichocephalic. Meso meaning middle, so it's the average skull shape that you would see. And the skull morphology is based off of the degree of angulation of the petrous pyramids to the mid-sagittal line. So here's your mid-sagittal line. Here's your 3 types of skull. Meso is in the middle. It is 47 degrees. And then you've got brachycephalic. Brachy means short, so they're kind of short and wide. So it would make sense that it's a larger angle. And then dolichocephalic, dolicho means long, so it would be long and narrow. So that's going to be the smaller of the angles at 40. So you've got meso in the middle at 47, brachy at the larger end of the angle because it's short and wide, and then dolichocephalic on the smaller end, which is 40 degrees because it's long and narrow. I'll just give you guys a second to take any notes you need to take just in case. Okay. As I mentioned earlier, there are going to be several questions about positioning considerations. So there will be situations that you have to actually think about. How did I position the patient, or how would I change the positioning? Again, that's all in the evaluation criteria for the projections you're responsible for cranium. You will need to know for sure your apiaxial tone, your PA Caldwell, your straight PA, your PA Haas, your lateral, your SMV, and I think that's it for cranium. The reason why those projections are so important is because they're going to carry on into your facial bones. Facial bones does have a few extras, but those are the primary ones. So if you get them down for cranium, it's pretty easy to remember them moving forward into facial bones. The only thing that changes is your central ray, where it enters and exits, because cranium is up higher and then your facial bones are clearly lower on your skull and on your head. Anyway, positioning and technical considerations. You need to kind of keep in mind erect versus recumbent. If you're ever looking for air fluid levels, you obviously want to make sure that the patient is upright and you have a horizontal beam. If you're going to angle anything, you have to angle the patient, not your central ray. So that is to be able to tell air fluid levels. If they're recumbent, then it's a different story. You can do whatever you need to do if you're not looking for air fluid levels. But anything air fluid related should be erect and with a horizontal beam. Okay. Most skull work is done at 40 inches. Some hospitals can do something different, but for your test purposes, you need to know 40 inches. You want to use a small focal spot because you want fine detail. And obviously you want to shield as best as possible. 5 common positioning errors that can occur and will occur in your lifetime. Nobody's perfect. It's going to happen, especially with skull work. Number 1 and number 2 are the most common, which is rotation and tilt, and that's kind of why your Bontrager put those 2 up. So if the patient is rotated anteriorly or posteriorly, and if they're tilted, so if their head goes down or if their chin goes down in one direction, those 2 are the most common. Anytime you have rotation, you're almost always going to repeat the image because you want to make sure that everything is completely superimposed. That's why I pointed out the stella turcica for the lateral, and then AP, obviously you want to make sure that everything is equidistant. The other 3 would be excessive flexion excessive extension, or incorrect central right angle. That happens a lot too. Sometimes people get confused between the Town and the Caldwell. Until you get used to it, or if you do a lot of skull work, that's when you'll start to remember the different CR angles a little bit better. Just a couple images of a PA. I wanted to point the PA out versus the PA Caldwell with the 15-degree angle, or the PA Caldwell with the 30-degree angle. Very important. Your petrous ridges are going to give it all away. They're going to tell you exactly what degree of angulation of the central ray you've used. So the PA has no angle on the central ray. This is not rotated because you see the sella turcica is nice and in profile. And for any Caldwell, the nose and forehead is going to touch. And you want to make sure your OML, your orbital meatal line, is perpendicular to your image receptor. And the reason you know that there is no angle on the central ray is because your petrous pyramids are completely filling your orbits. So you're not seeing that nice open orbital space. It's completely filled by this white junk here, which is all your petrous ridges blocking that area. So that is no angle, 0-degree angulation, no angle there filling the orbits. Okay, super important. Now, just again, something to show you, erect versus recumbent. Recumbent would be trauma. Obviously, you're not going to make somebody who comes in boarded and collared stand up. I should hope not. I don't want to see that. Let's hope that never happens. And then erect positions would be obviously for air fluid levels, and it is easier for patients to extend. This person is doing an open mouth waters, but, ew, I don't want to put my chin on anything that's been used a million times. But anyway, moving on. That's it. So again, I said this would be short and sweet. I just want to go back to the beginning to make sure everything is pretty clear. There's going to be a lot of labeling. So all the images I went over, keep in mind, lots of labeling. Make sure you know them. Make sure you know your evaluation criteria, specifically what works and what doesn't work. Why is the image wrong, or what happened that you need to fix it? Do you need to change the central ray angle? Do you need to extend the patient's neck? Do you need to flex the patient's neck? So very important that you know that evaluation criteria. Also, there are going to be some images taken from your Bontrager's book, page 442, which are for evaluation criteria and critiquing. So make sure that you pay attention to the ones specific to